Hi, everyone. I'm Steve. I'm here with Dr. Nario. Thanks for being here, Doc.
Hi, Steve. Thank you for having me again. Oh, it was a pleasure.
All right, so we're going to talk about sleep. We're going to kind of get into some sleep apnea stuff, which is very fascinating. But sleep is right there with having your hormones right, your diet, exercise. Sleep is like what? One of the top three, wouldn't you say, most important things?
I think it's top one or two. That's
All
where I
right,
put it.
so we're going to get into it. So first, if you guys want to know more about Dr. Nario, what he does, he is at Biointegrative Health Center in Reno, Nevada. That's the clinic where he is. If you want to know more about peptides, I'll put a couple links in the description because they're fascinating and you can find out more about those. So, Dr. Nario, now we were talking a couple weeks ago and I was tested for sleep apnea. No symptoms, had no symptoms, nothing. And I was shocked that I had like 32 breathing events or not breathing events an hour. So that's not good and totally shocked me because I slept good. I wake up refreshed and relaxed and I never would have known. But my hemoglobin and hematocrit was high. So I said, hey, I want to eliminate this process of elimination, and boom, surprise. So what are your first thoughts? I mean, sleep is critical. And do you have any, numbers on how many people have this, or should you get tested? We were kind of talking about that before we turn this on. So what do you think?
Yeah. So when we hear the word sleep apnea, the first thing that comes into our minds is like a man who's overweight, snoring like a
Not
chainsaw,
me.
stops, right?
No
Stops breathing at
snoring.
night, no snoring at all. But this is the typical picture. They stop breathing at night and wakes up exhausted. And yes, the patient absolutely exists. But here's the problem. That is not the only patient with sleep apnea. I see patients who are lean, active, relatively healthy, and still having significant obstructive sleep apnea. And sometimes they tell me, Doc, there's no way I have sleep apnea. I don't even snore that loud. And I say that's exactly why we need to talk about it. Because when we're talking about healthy aging, we spend a lot of time discussing hormones, mitochondria, inflammation supplements, peptides, and sometimes we forget about the most powerful anti-aging intervention of all, getting a good night's sleep. You can have the world's most sophisticated supplement protocol, but if you're, I guess, stopping in terms of breathing 30 times an hour, as you said, like your mitochondria is probably not impressed by that specific performance. So when you ask me about like percent, the majority of sleep apnea patients, they show up in male, right? In the male population. In women, most of them appear when they are in the menopausal period. So when hormones go down eventually, and we're going to talk about that also, a lot of this always presents mostly, so 50, 60% shows up with the typical symptoms of snoring. Half of that, not typical. Like, as you said, maybe you, right? You're just like a little foggy, hematocrit's high. So those are not typical symptoms. So that's 50-50. It's like a flip of a coin. And then again, with the age, more than 65-year-olds are the ones affected by this the most. And with the obesity, again, I guess this is a huge contributor. 50 to 70% of obstructive sleep apnea are in this population. Here's another fun fact. If you do find out that you have sleep apnea, what's next? You're going to be using a CPAP. Long-term adherence, 50%. So another flip of a coin that people are going to get used to that and continue using it. And the good thing about this now is another, if you want numbers, there is now the approval or Tirzepatide to address moderate sleep apnea in patients. It will be covered by insurance. And mostly because of the weight loss that it produces almost 40 to 50% decrease in this, the improvement of the sleep apnea episodes. So those are the numbers that we have to look out for. And even as you see, conventional medicine is helping out in this fight against sleep apnea.
So did you say that it helps people lose weight?
Tirzepatide. So
Tirzepatide, yeah,
yeah,
that's the
that's right.
GLP-2.
Right, that's correct. So tirzepatide is the one that actually is the one that makes it lose weight. in relation to to address the sleep apnea, basically.
Right. So the GLP-1s, there's multiple ones out there. They help you lose weight. And then when you lose weight, it helps eliminate the sleep apnea.
Right, that is correct.
Right. That's what I knew that.
Thank you.
The different weight loss medications, which there's a number of them.
It's only Tirzepatide that's approved by insurance, not the other ones.
Yeah, but if you lose weight, I mean, what if you don't use Tirzepatide? You could lose weight another way. So however you lose weight, that should help, right?
That is correct.
Interesting. But not interesting, but not surprising. It doesn't
Not
surprise
surprising.
me.
Mm-hmm.
So do you know how many people, you said this occurs commonly with people over 65, especially males?
Right. Meaning the percent? Is that what you're asking?
Yeah. Do you have any idea? Did you
Yeah.
that?
So the majority of the reason why, again, when we talk about it happens to this population around, again, 40 to 50%, is because, of course, you lose hormones, you get sedentary. Mostly it's the weight gain that happens in that increasing age group. And it's just not, don't take it with a grain of salt that everybody who gets old at 65 will just get obstructive sleep apnea. It usually comes with these added modifiers or the risk factors. So this is the one that we need to look behind the scenes when we read statistics that, what's behind the number?
So what do you think about someone like me? I'm fit. I'm probably 13% body fat. I'm really fit. I lift weights. I exercise 5 times a week. I don't snore. I wake up rested. I'm certainly not fat. I don't have any symptoms. I'm 64 years old. What is that odd?
Well, you're classified as we call the lean obstructive sleep apnea patient. So the one that we always have, I guess, like a stereotype of the one who has obstructive sleep apnea is the one who is like the bigger, obese, right? And this is a major mechanical problem. If you think about it, there's more tissue around the surrounding airway, and it's like a garden hose, right? Add pressure to that surrounding tissue, it decreases the stabilizing forces, and eventually the hose collapses, and that essentially what happens during their sleep. And this is why weight loss can be such a powerful intervention for these population. And when I mentioned about weight loss, by losing 10% of your weight, you actually have a 25 to 30% reduction. It's called the apnea hypopnea index. It's like a score that lowers that or improves your oxygenation while sleeping. So for this type, weight optimization can be incredibly important, and this is where the GLP-1s that we spoke about comes into play. Going back to you, not every airway problem is a weight problem. There's a substantial group of patients who are not obese, and sometimes they're the patients that we miss. Of course, us clinicians, meaning, and this is the one with normal BMI, normal neck. But here's some clues. They have, for example, their chin is not aligned with their maxilla. So meaning the chin is like backwards a little bit. High arcing palates, narrow airways, and then large tongues, right? Like people who are deficient in B12, for example. Nasal obstruction, who's always congested. Abnormal upper airway muscle tone. So imagine these two patients, one needs to lose weight, the other one actually needs to move their jaw forward because the jaw apparently decides to take a vacation going backwards. And these are different classifications. For the lean patient, simply saying lose weight may not address the primary problem. So this is why we start thinking of other options like myofunctional therapy, muscle training of the oral area, mandibular devices. So all of these other things that we could do. Again, BMI does not tell you everything about the airway.
So I've been using my machine for about 6 weeks now. My events per hour have gone from 32, 34 an hour down to usually between 2 and 4 an hour. So what can I expect or what can anyone expect as far as the benefits of that? And when would you notice those benefits? And like what would they be?
Yeah, so the thing with you is it's a good thing that you're compliant. As I mentioned to you, it's a flip of a coin that a patient will be compliant using a CPAP machine. So that's really good to hear from you. So really the key here is compliance in relation to the usage of the CPAP, because that's the number one intervention when somebody got diagnosed with OSA, as we call it. The other interventions, well, let's go back to your question. How long will you see it? It really depends. So you have to remember, putting a CPAP machine on for the patients who actually are with obesity, you're basically just putting a band-aid there and again preventing the bleeding. We always want to go back to that discussion of you have to lose weight. You have to make sure your hormones are balanced. You have to make sure your minerals and vitamins are also be getting checked. And then you will basically will get relief from using the CPAP machine. So that usually will be seen again in a month or 2 months already, but it's not the maximum effect. You really still have to remember that the CPAP machine is mostly a band-aid, and you have to treat the underlying cause, which is basically the weight. And again, if you're talking about if you're the lean type and you have anatomical issues, a CPAP machine again is just a band-aid. You need to fix the anatomical defect. You need to put that that uh, that jaw in front again through devices, and also sometimes they even go through procedures, even therapy. But again, the CPAP machine will save any type of obstructive sleep apnea patient, but you have to go to the root cause.
So I'm kind of an outlier. I mean, from doing the therapy, and I wear like a mouthpiece at night. My dentist wants me to wear it so I don't grind my teeth. So that kind of puts my jaw in position. And I had no symptoms, but can I expect anything? Someone like me, I don't need to lose weight. There's none of those things that I need to address that are the root cause of it because I don't have them. So what can someone like me expect as far as benefit? I feel better. I would say I sleep a shorter amount of time. I don't, here's one thing I don't really like about it. It's kind of the one symptom that I had was I like to take a nap, a 30-minute nap at 2:30 or 3. Now that's hard to do. That's kind of a bummer. I like my naps.
Right.
So what can I look forward to as far as benefit? Anything?
Yeah. So here's the thing. So
Because I want my naps back.
you want your now, you're gonna get it back for sure. The thing here is there is also another perspective that you have to look into. Talking about the symptoms. So symptoms can be actually your parameters of improvement also, if they improve or not. So another reason why we're missing OSA is we're looking at the wrong symptoms. The classic patient now snores loudly, right? And partner says, "Stop breathing. You stop breathing at night. You have sleep apnea episodes, as they call it." So they wake up gasping, they're sleepy during the day, easy. And many patients don't present that way, especially women, lean patients, and older adults. Instead, they say, "I can't stay asleep. I wake up 3 or 4 times a day. I mean, at night. I'm exhausted, but I'm not actually sleepy. My brain doesn't work in the morning. I'm anxious. My memory isn't what it used to be. I have headaches when I wake up, or I haven't slept for 8 hours, even though I was in bed for 8 hours." So that's a very important distinction between, again, fatigue and sleepiness. So patients have significant sleep disordered breathing without walking around looking like they're going to fall asleep at their desk. And occasionally the patient says, "I don't snore." And the spouse says, "That's because I stopped sleeping in the same room." So don't let the absence of symptoms end the investigation. Where my point here is with those things that I just mentioned to you, those symptoms, that's very subtle symptoms that you think that is not related to sleep apnea, suddenly goes away. And for you, I think you mentioned about your hemoglobin hematocrit. As you now use this, you will be monitored now in relation to those numbers improving as you basically use the CPAP machine, or even your little naps here in there, right? Those are the ones that will be your individualized parameter to actually see improvement just in your specific case.
So if listeners out there, if they're like me, if they're fit, they're in their 60s, 70s, 50s. I mean, you can have sleep apnea at a younger age, but should everyone get this test just to make sure? Because it really surprised me with my level of health in all areas and no symptoms. So how do you know? Should everyone just get this test, or what do you
Yeah.
do?
So, because OSA, again, especially for our anti-aging audience here, is not simply a problem of snoring. Repeated airway collapse leads to low oxygenation, disturbances, sympathetic activation, and even oxidative stress and inflammation. So those pathways overlap with many things. So we worry about in our aging process high blood pressure, atrial fibrillation, cardiovascular disease, metabolic syndrome, insulin resistance, dyslipidemia, fatty livers, cognitive issues, forgetfulness, right? Mood disorders, sexual dysfunction. So when someone comes into our clinic and asks us, what can I do? How can I get assessed for this? Do I need it? So before giving them another bottle of supplements, now this is the time when we say, hey, let's assess this, because it's just, again, it can present in so many different ways. It can even be mistaken as, I see a lot of mold patients and even Lyme patients. They think that, oh, it's just mold, it's crazy mold, it's Lyme that's doing this to me, until we actually address the issue that it was sleep apnea and we had a CPAP for them. The fatigue went away, brain fog, memory, anxiety, depression, body aches, insomnia, even poor exercise recovery, all just resetted itself, and we didn't have to deal with mold and Lyme at all.
Hmm. I will say that, my glucose is dialed in. I just got some blood work. My A1C is 5. My glucose is like clockwork, 75 in the morning, fasted glucose. My blood pressure's 105/65, like clockwork. And yet I had this issue. So I'm glad I got it tested. And I will say that after 5 to 6 weeks, I do feel improved. I like the machine. I can tell that I'm breathing much smoother at night,
Mm-hmm.
just having it on, and it's not uncomfortable. It's like now I'm kind of addicted to it. I got to make sure I have it on.
You like to be Darth Vader.
Well, I have a really light little mask. It's just a little band that goes around here, and it's not cumbersome. It's not invasive, really. It's totally easy to sleep with. And I mean, obviously, I'm glad I did it, and I think that I don't know. I always feel good. So, hey, maybe another month or so, I'm going to feel even better, right?
Yeah, well, you mentioned about how can you, I guess, assess the risks, like in terms of for you blood testing. So in terms of blood testing, definitely I would suggest everybody who actually wants to look into this a little deeper. So these are the specific conditions that actually affect sleep apnea. One, check your thyroid. So hypothyroid conditions leads to, for example, swelling of the tongue. It actually leads to weight gain, even fluid retention, and even soft tissue swelling. Another one is testosterone. So check if your testosterone is low, because of course, when your testosterone or your T is low, you will have more fat, visceral fat. It changes the upper airway muscle function, and even it alters the ventilation control of the body. And again, this is not a treatment for sleep apnea, but it aggravates it if it's low. And then the other one is for females, check hormones, because menopause definitely affects and aggravates the condition of OSA, because estrogen and progesterone affects, again, upper airway function, ventilation drive, and as we know, as they get into menopause, fat distribution becomes a little bit more different. It goes into the different places that they were never there before. And again, these are just simple combinations that you could definitely tell your doctor to check if you're really thinking like something's off. I think even just having that thought that there's something is wrong here, I just can't put a finger on it, I think OSA is something you should look into.
Well, I guess, and you know this, the reason I did it is because my hematocrit and hemoglobin was high. And I wanted to eliminate sleep apnea as being part of the cause of that because I'm on TRT, and lo and behold, I had sleep apnea. But so that's why and now hopefully that will go down some, at least by getting the therapy.
Right, right.
Well, any last thoughts, Doc, comments, or suggestions for people?
Yeah, so if you just want to remember just a few things from our discussion here. One, sleep apnea isn't synonymous with obesity. Two, a lean patient can have severe OSA still. Number three, women or even older adults may present with fatigue, insomnia, headaches, or brain fog rather than the classic sleepiness and loud snoring that we always affiliate OSA with. And number four, hormonal metabolic problems can amplify OSA, but they don't replace proper diagnoses and treatment. And finally, before we spend thousands of dollars trying to optimize someone's longevity, let's make sure that they're actually breathing while they're sleeping. Because sometimes the most sophisticated anti aging intervention is simply getting 8 hours of uninterrupted oxygen delivery while you're sleeping.
Yeah. Well, thank you, Dr. Nario. And as always, we appreciate you being here.
Thank you, Steve, for having me again. As we all know, that knowledge is power. And thank you for letting me provide you with longevity and health maintenance, which I call the biological edge or the bio edge.